Record.
Thank you. So, good evening once again to this September month session of nursing class. I sincerely thank Dr. Siaram and his team for taking up the session today. The topic is a very pertinent one for the nurses working in pediatric hematology oncology department. It's febrile neutropenia. I'm sure everyone will be coming across this condition every day. Though it is very well known and managed day
Dr. Dharani, your voice is breaking. You're not audible.
for taking up this topic today. I now hand over to Dr. Siara and his doctor Henuka Verma, who will be talking about the medical aspects of febrile neutropenia management, and his nursing staff, Mr. Dilip Singh, who will be talking the nursing perspective. Hand over to Dr. Siara to moderate the session further. Thank you.
Thank you, Dr. Dharani. Speaker one. So we already ready and we can start. So febrile neutropenia definitely is a very important topic in the all hematological malignancy, and timely suspicion and emergency early treatment is the only life-saving measure. And for that, nursing team is very crucial for that, along for treatment part along with prevention part. So over to Dr. Henuka to start the session.
Good afternoon, everyone. Today, in today's session, we'll be discussing about febrile neutropenia, its medical and also nursing management part. So I'll be discussing management part, and a nursing officer, Dilip Singh Shekhawat, he'll be discussing the nursing care part. So the objectives for today's session are introduction to febrile neutropenia, some background information, definition, epidemiology, pathology of immune dysfunction in PHO patients with febrile neutropenia, clinical severity scores, diagnosis and suspicion, management and prognostic markers. So febrile neutropenia, as we all know, in childhood malignancies, childhood leukemia is the most common malignancy. The cytotoxic anti-neoplastic agents that we are giving as part of our chemotherapy, they also affect the myelopoiesis. The cells with high turnover, such as GI mucosa, they are at increased risk of infection because of the colonizing bacteria and fungi. The neutrophil mediated inflammatory response, which is normal in a normal patient, but it could be absent in neutropenic patient because of chemotherapy and also because of the underlying malignancy. And fever may be the earliest and the only sign of infection when a child presents with febrile neutropenia. So, coming to background, why learning about febrile neutropenia is important. First of all, it is critical to recognize neutropenic fever early for early initiation of empiric antibiotic therapy, which will further improve the patient outcome. And aggressive management, it prevents progression to further fulminant sepsis, and which will eventually lead to death. And so it is seen that survival of children with hematological malignancy, it has improved significantly with improvement in supportive care, especially in terms of management of neutropenic fever. So the definition, as the term suggests, febrile neutropenia. We have fever, we have neutropenia. So fever is a single oral temperature of 38.3 degrees centigrade or 101 Fahrenheit, or a temperature of at least 38 degrees centigrade, 100.4 Fahrenheit for 1 hour, or a fever that occurs twice within 24 hours. That is fever, and neutropenia is ANC less than 500 or an ANC of less than 1000 in the next 48 hours, or the child has. So coming to epidemiology, the children that we are treating with chemotherapy, or the patient with the transplant, in one third of the neutropenic patients, fever will occur, and there are 0.76 episodes per 30 days of neutropenia. And neutropenia is more common in hematological malignancy, that is more than 80%, as compared to solid patients with solid tumors. And clinical documented infections, they occur in around 20 to 30% of febrile episodes. Episodes are associated with bacteria. Bacteremia with gram-positive organisms is around 57%, and with gram-negative organisms is around 34%. But the mortality with associated with gram-negative infections is more, that is 18%, as compared to gram-positive pathogens. Coming to pathology, pathology is multifactorial. What are the factors that contribute to the pathology? First of all, we have pancytopenia. It could be secondary to the cytotoxic due to marrow replacement by the leukemic cells. Second, we have the child already has malignancy, and this malignancy, it affects the chemotactic and phagocytic function of the neutrophils. So that will further lead to febrile neutropenia. Then, due to chemotherapy, there can be in the
We sharing the screen again.
Okay.
Just going to check. I request all the participants to post their queries and comments in the chat box. We can take up at the end. It's a very important topic, so try to have your practical doubts cleared and discussed here. Thank you.
Hello, is visible to screen again?
Yes, yes.
Yes, sir.
Okay, we are starting again.
So continuing with the factors that contribute to pathology. First one was pancytopenia, secondary to cytotoxic drugs or marrow replacement by the leukemic cells. Second is malignancies. They itself cause chemotactic and phagocytic defects in neutrophils. Next is mucositis. That can be secondary to the chemotherapy that we are giving. It will lead to breakdown of barrier in the GI system, and which will eventually cause translocation of commensal bacteria and fungi into the bloodstream, which will lead to sepsis. Then we have to place central venous catheters for giving chemotherapy. That will lead to colonization with skin commensals. So what are the predisposing factors for an invasive bacterial infection? The factors could be mucositis, intravascular devices, depression of immune function and abnormal neutrophil function because of chemotherapy, longer duration of neutropenia, more than 30 days, profound neutropenia, less than 100 ANC, and concurrent immunosuppressant therapy. What are the common bacterial pathogens that can cause febrile neutropenia? We have both gram-positive and gram-negative pathogens. In gram-positive pathogens, the most common is Staph aureus, and in gram-negative pathogens, the most common is Pseudomonas aeruginosa. Others are cons, then Enterococcus, Streptococcus species. In gram-negative pathogens, others are E. coli, Klebsiella species, Enterobacter, Citrobacter, Acinetobacter. In anaerobic pathogens, Bacteroides species is the most common organism. In viral pathogens, respiratory syncytial virus and CMV are most commonly implicated. And other than that, we have HSV, Epstein-Barr virus, influenza, parainfluenza, rhinoviruses, adenoviruses, coronaviruses. Now, other than bacterial and viral, we have invasive fungal infections. But for invasive fungal infections, we have certain risk factors. These risk factors could be profound and prolonged immunosuppression. If the child is on high-dose steroids, prolonged courses of broad-spectrum antibiotics have been received by a patient previously. The most common fungus that are involved are Candida albicans, which is mainly found when the child has mucositis, Candida glabrata, tropicalis in patients who have received azole prophylaxis. Then Aspergillus in chest, CNS, bone, and skin infections, and Fusarium and mucormycosis is also found. A clinical criteria of a patient, clinical criteria for high risk febrile neutropenia. So in this, first of all, we have, if we are suspecting prolonged neutropenia, that is more than 7 days of neutropenia. Second, we have profound neutropenia, that is less than 100 ANC. Then there is hemodynamic instability, mucositis, which is interfering with swallowing of food items, intravascular catheter infections, and system-wise, we have GI involvement, abdominal pain, nausea, vomiting, diarrhea, and if there have been new pulmonary infiltrates or new onset hypoxemia or underlying chronic lung disease. In liver, if AST, ALT is elevated more than 5 times of normal, if there is renal insufficiency, or there has been new onset neurological complaints or new onset mental status changes. So all these classify as high risk patients with febrile neutropenia. Now, how do we try children with FN? So a child with febrile fever can present either to the OPD or to emergency, or if there is a daycare that is being set up in the institute, the child can present to daycare also. So first thing we have to see is that if a child presents with fever and who has come for any emergency medical treatment and has received chemotherapy in the past 6 weeks, we have to consider it as febrile neutropenia and assume that there is a bacterial infection that is ongoing. First, we have to document the fever and take pre-treatment blood samples. We should conduct a systematic assessment, which will include history and examination, and we should decide on antibacterial of choice, and we should think of the prognosis also. All this should be done within the first 15 minutes. And within first 1 hour of reaching the patient to the hospital, we should start empirical antibiotics, which is the golden hour. This first 1 hour is called the golden hour because, and this golden hour is important not just from the medical point of view, it is also important from the nursing point of view, because at many places the sampling is being done by the staff also. So withdrawing the samples and putting a good IV access and starting the empirical antibiotics as advised within first hour is important, because within first hour, if we start antibiotics, it will improve the further outcomes. It will decrease the mortality and morbidity that will further occur due to febrile neutropenia. So now the child has already presented to the emergency. We have diagnosed that the child has febrile neutropenia. What all first line investigation we should send? So a CB complete blood count should be sent with which includes differential counts and platelet. Patients KFT, LFT, and serum electrolytes is important. We should always send a blood culture, and if possible, we should send at least 2 sets, and even 3 sets can also be sent because it increases the sensitivity of our blood culture. And a clean catch bacterial urine culture should be sent if required, and further culture specimens can be decided based upon the site of infection with which the patient is presenting, such as skin, oropharynx, or if there is a central catheter present. Additional investigation that we can send is inflammatory markers. We can order a VBG for seeing the lactate in very sick children, and also to see electrolytes immediately. Then we can order a chest X-ray if the child has complaints of respiratory complaints, and CT paranasal sinuses. For paranasal sinuses should be ordered if sinusitis is suspected, or even if when we are suspecting a fungal infection. Then in further additional investigations, we have if the child has esophagitis, child has mucositis, but we are thinking that it has progressed to esophagitis, then we should order an endoscopy with biopsy. If the child has diarrhea, stool microscopy and culture. Then with child presents with neurological signs, then a head CT or MRI is the should be ordered, and MRI is the preferred investigation for seeing the neurological status. Then abdominal ultrasound. Abdominal ultrasound, it is a additional investigation, but it can be considered if the child has persistent fever even after 72 hours to assess the fungal involvement of kidney and liver. So the common differential diagnosis that we can consider with when a child, we are suspecting a child with febrile neutropenia, but we have to think of other causes of fever also. So the child might have drug fever. Drug fever can be because of the antibiotics that we are administering, or because of the chemotherapy drugs, such as common drug that causes fever is our cytarabine. Then if the child is being monitored for tumor lysis. If a tumor lysis is going on in the child during the induction phase of chemotherapy, that time also child can have fever. Then it could be because of HLH, blood transfusion reactions, or dysautonomia if there is CNS involvement because of the disease. Now, the basic approach to for a child with febrile neutropenia. So when the child presents, we have seen that there is fever, there is neutropenia. So we will classify that the child has febrile neutropenia. We have taken the detailed history, examination, lab investigation, or imaging. Then after that, we have to do risk group assessment. So we can classify as low risk or high risk. In low risk, the ALL patient, non-Hodgkin lymphoma, and solid tumors in remission, all these can be considered in low risk. If the neutropenia duration is less than 7 days, child is non-toxic in appearance, there is no focal infection, mucositis, diarrhea, then we administer empiric antibiotic therapy, and usually monotherapy is recommended, and patient can be managed on outpatient basis. But if the child falls in any of this criteria, that is, the child is high risk for febrile neutropenia, then there is a need for immediate hospitalization, starting of empiric therapy, broad spectrum antibiotics, and the treatment of comorbidities along with pain management. So after classifying patients as low risk, high risk, we have initiated antibiotics. We have started both the risk groups on empirical antibiotics. Now we are following patient. So after 2 to 4 days of fever, we have to follow the patient. Now patient there can be 3 scenarios. The patient might have a persistent fever, and child becomes clinically unstable. Second scenario is fever might have subsided and cultures are negative, and third one is there is documented infection. So if the child has persistent fever and child is clinically unstable, the first thing we should do is hospitalize for broad spectrum IV antibiotics, because initially we had given oral antibiotics and we were managing the child on OPD basis, and we have to modify antibiotics as per the culture or the infection site. After modifying antibiotics, if the child responds, we have to continue antibiotics for 7 to 14 days, or till ANC is more than 500, or there is a rising trend in ANC. But if the fever has subsided and cultures are negative, we continue the oral or IV antibiotics till the ANC is more than 500. But if documented infection is there, that the cultures come positive, then we have to modify antibiotics as per the culture results, and then we have to see the response. If the response is there, we continue antibiotics. If there is no response, then we have to restart from the first step, reevaluate the patient. We do reimaging, we do cultures, biopsy, drain, and also consider adding antifungals. Now the same patient, if the patient is in high risk group with persistent fever. So in this also there can be three scenarios. First can be fever has subsided, cultures are negative, so we will continue antibiotics until ANC is more than 500 or rising. But the child has persistent fever and so child has persistent fever but otherwise stable. So we will not change the antibiotics and reassess for infection sites. But there is documented infection, so we will modify antibiotics according to culture or infection site. Now this is psychosocial and logistic management for OPD management. So in this, according to this, we will decide what all patients we can manage on OPD basis with oral antibiotics. So first point is if the child resides nearby hospital, that is child can reach after developing fever, child can reach the hospital within 1 hour or resides within 48 kilometers of the hospital so that we can administer antibiotics as soon as possible. Second one is few patients who are not continuing treatment at the nearby hospital, they are taking treatment from some other place and they might present to some other physician. So the decision of OPD management should be taken by the primary care physician or the oncologist. So it has to be discussed with the primary care physician and oncologist whether to manage this patient as OPD patient or patient needs admission. Second thing is whether the patient and attendants are able to comply with the logistic requirements, including the frequent clinic visits, because we have to call the patients after 2 days for reassessment. And family member or a caregiver should be present at home 24 hours a day with the child. Then there should be access to telephone or transportation 24 hours for daily, and there has been no history of non-compliance with the previous treatment protocols. So if all these things are present, then we can consider for OPD management for patients with febrile neutropenia. Otherwise, they need hospital admission. So coming to the antibiotics of choice. So empirical antibiotics, in empirical antibiotics that we are giving orally, recommended is ciprofloxacin plus amoxiclav combination. So mainly we are giving fluoroquinolones, but if a child is already on fluoroquinolone prophylaxis, they should not receive oral empirical therapy with a fluoroquinolone because child is already receiving. Now empirical antibiotics for inpatient management. So in inpatient management, of course, we will be giving IV antibiotics. So this should include gram-negative coverage, including pseudomonas. There is option of monotherapy and dual therapy. In monotherapy, there is 4th-generation cephalosporin beta-lactam agent, for example, cefepime. Carbapenem, example, meropenem, piperacillin, tazobactam. And in dual therapy, we have to give anti-pseudomonal beta-lactams plus aminoglycoside. But this antibiotic policy, it has to be streamlined or individualized as per the institute protocols or as per the institute culture sensitivity. Now, with what should we give? Monotherapy or dual therapy? So the multiple meta-analysis have been done, and they do not show. They have shown that monotherapy with broad-spectrum antibiotics is non-inferior to dual therapy. But dual therapy can be considered in settings such as settings of hemodynamic instability, suspected antimicrobial resistant, need for synergy. if there is need for treatment of Enterococcus mycobacterium or MRSA species, or there is patient requires treatment for endocarditis or cryptococcal meningitis, then dual therapy is indicated. So now next question is when to add vancomycin to the empirical treatment. Vancomycin is indicated when we are suspected catheter-related infections, skin or soft tissue infections. There is colonization with MRSA. The child has hemodynamic instability such as shock. There is mucositis. There is prior history of infection with alpha hemolytic streptococcus. Then there is severe pneumonia. There is a picture of ARDS and positive blood culture for gram-positive bacteria. And there are vegetations on echocardiogram or AML cases. In all these cases, we have to add vancomycin as part of the empiric therapy. Now, modifications to the initial empiric therapy. So when to suspect infection with a resistant organism? If we are suspecting infection with a resistant organism, such as there has been previous infection, colonization with the organism, or treatment in a hospital with high rates of endemicity. So in these cases, for the antibiotics are antibiotics for choices as per the organism. If the child is allergic to penicillin group, then we consider either ciprofloxacin plus clindamycin combination or aztreonam plus vancomycin combination when there is allergy to penicillin. And there are certain indications to add an anaerobic coverage. These indications are mainly these are GI causes. In GI causes, we have typhlitis, neutropenic colitis. Neutropenic colitis is one of the dreaded complications which is seen in febrile neutropenic patients, which can eventually lead to death. And there is significant mucosal breakdown, perianal skin breakdown, peritoneal signs or other abdominal pathology, and there is a documented Clostridium difficile infection. Then we have to add anaerobic coverage. The next question is to add antifungal therapy. When should we add and what to give? So whom should we give this antifungal? First is high-risk patients who fit the clinical criteria for high-risk patients. Then if the child has persistent or recurrent fever even after 4 to 7 days of broad-spectrum antibiotics, and the expected duration of neutropenia is more than 7 days, so, then we should start antifungal therapy. And what antifungal should we give? Anti-mold coverage is recommended, in which we can give echinocandins, that is our caspofungin, micafungin, voriconazole, or amphotericin B. In antifungals, no particular antifungal has been considered superior to as compared to other, but usually echinocandins are recommended first-line antifungal therapy that should be given. Now, if a high-risk patient, if a febrile neutropenia patient has been classified high risk and the fever is persistent even after 4 days, so we should do a daily examination and history should be reviewed. Repeat blood culture should be sent. Cultures for any other suspected sites should be sent. So in these patients, the child might have unexplained fever. Child can have unexplained fever, but child is clinical stable with rising ANC. We will observe the child with no antimicrobial changes. But if there is unexplained fever and child is clinically stable and ANC is not rising, then ANC is not rising, then we have to consider CT scan of sinuses and lung. In this, in the therapy changes by if the child is receiving fluconazole prophylaxis, then we have to start preemptive antifungal based on CT scan and serum galactomannan levels. And empirical therapy is started with echinocandins, voriconazole, or amphotericin B. And if the child was receiving anti-mold prophylaxis, such as child might be receiving voriconazole, then we have to switch to a different class of mold antifungal. The third scenario was that there is documented infection, child is clinically unstable, and there are worsening signs and symptoms of infection. Then the same thing we have to do, re-examine the child, do a re-imaging. We have to send fresh cultures or biopsy or from the drain sites if there is worsening infection, review our antibiotic policy, broaden antimicrobial coverage, and again consider empirical antifungal therapy. Now we have started antibiotics for our in the febrile neutropenia child, but when should we stop this antibiotic therapy? So in patient in which we have documented infection, so if there is gram-negative infection, the antibiotic should be given for around for 10 to 14 days. In gram-positive infections, the recommended duration is 7 to 10 days, or until ANC is more than 500, or there is a rising trend. If dual therapy or vancomycin was started empirically, then it can be stopped after 24 to 72 hours after initial presentation if the fever has subsided and there are no new clinical signs and symptoms and all the cultures are negative. The discharge criteria for FN patients is that the fever has subsided, all the cultures are negative, neutrophil is in recovery, that is more than 500, or there is an improving trend, or it's a simple FN with stable vitals and good oral intake. Oral intake, other than fever, oral intake is an essential thing that should be ensured before discharging. Then whom should we start on antibiotic prophylaxis? In so to whom should we give the high-risk patients with expected prolonged and profound neutropenia, such as AML patients who are receiving high dose of chemotherapy, or children with relapsed ALL. In all these patients, we have to give prophylaxis. What to give? That is fluoroquinolones, that is levofloxacin and ciprofloxacin. Then addition of any gram-positive agent is generally not recommended. And when to start? It should be started either on the first day of chemotherapy or on the the day following the last dose of chemotherapy, and it should be stopped after the neutropenic period is over, or if the patient develops fever, then antibiotic prophylaxis should be stopped and empirical antibiotics should be started. The antifungal prophylaxis is recommended mainly for Candida species. It should be given in children who are receiving intensive chemotherapy, in AML patients or transplant patients. Or for aspergillus, we have posaconazole that is recommended usually after 13 years of age or on patients intensive chemo for AML or MDS. For PCP prophylaxis, the recommended treatment is trimethoprim sulfamethoxazole, and trimethoprim sulfamethoxazole, which is commonly known as Septran, it causes myelosuppression, but it should be given for around 3 to 6 months after completion of chemotherapy. And there are second line agents which can be used if someone is allergic to Septran. Then we can use oral dapsone, IV or inhaled pentamidine, or oral atovaquone. In antiviral prophylaxis, it is mainly done for HSV with acyclovir, or for influenza, oseltamivir can be started in case of there is a setting of an outbreak in neutropenic patients who present with influenza-like illness. So, role of hematopoietic growth factors. So, GCSF, it is not routinely recommended after establishment of fever and neutropenia, and it should be avoided during induction phase or simple febrile neutropenia, as there is no strong supportive evidence in ALL patients. Central venous catheters or PICC lines, they are associated with there can be colonization with skin commensals. So when should we remove PIC line or central venous line? So if there is a documented infection with Staph aureus, Pseudomonas fungi or mycobacteria, then there is tunnel infection or any pocket site infection is there, septic thrombus evidence is there, then endocarditis, sepsis with hemodynamic instability, and bloodstream infection that persist even after starting therapy, that is for more than 72 hours, the bloodstream infection is persisting, then we should consider removing the central line. Now, there are certain poor prognostic markers in febrile neutropenia. That is, there is previous history of febrile neutropenia, the time from last chemotherapy, as it will determine the further neutropenia. Then there is presence of central venous catheter, neutropenia severity and duration. Then we have lab parameters, that is monocyte less than 100. That means the marrow is not recovering. Hemoglobin less than 7, platelet less than 20,000. There is hypoalbuminemia, elevated CRP, lactate is high, and bicarbs are low. So that is that basically that is present usually in a sick child. So that will become a poor prognostic marker. There is evidence of malnutrition, hemodynamic instability, and requirement of intensive chemotherapy in further cycles. So take home message from this session is that febrile neutropenia is an oncologic emergency and early recognition is a critical step, and golden hour rule must be followed in all cases. There should be active screening of fever focus. Antibiotic upgradation and antifungal should not be delayed. There is a limited role for GCSF apart from medical management, supportive plays a major role, and the antibiotics should be individualized as per the institute policy. So in the next session, nursing officer Dilip Singh Shekhawat he'll be discussing about the nursing aspect of patients with febrile neutropenia. Thank you.
You can say any query. So any query can be discussed or we discuss after the next session.
So I think we'll discuss after the second talk also, because we have only 20 minutes left. So we can finish the nursing talk, then we'll address the questions at the end.
Okay.
It was a very comprehensive presentation, Dr. Hemika.
Yes, yes.
Almost all the points were very well and adequately covered. Thank you so much.
Thank you, ma'am.
Yeah. The next speaker is ready?
Yes, yes. Just be sharing the screen.
Sure, thank you. I request not to repeat the points and
we-
try to finish in next 15 minutes or so that we can
already
have some
taken care of
few
same.
minutes.
Yes, yes.
Sure, thank you.
Yeah. Okay. आगे delete इधर ही इधर नहीं confidence लगना चाहिए. Yes.
Good evening, everyone. Myself, Dilip Singh, nursing officer, PHO daycare. Today we are going to nursing care of patient with febrile neutropenia. We are going to discuss objectives. First are introduction, second is environment precaution, nutrition, neutropenic diet, skin care, oral care, additional precautions, patient and family education, nursing care and pickline care. First, we are discussing the introduction. Febrile neutropenia is a medical emergency like stroke or MI. Febrile neutropenia is one of the most common oncology emergency. Fever may be the earliest and only sign of infection. Nursing officers should be especially trained in the prevention, recognition, and management of febrile neutropenia so that patient prognosis will be improved. Environmental precautions, hand hygiene, isolation and barrier precautions. Standard barrier precaution for all patient PPE, gown, gloves, mask when contact with body fluids. Isolation. Patient with certain symptom may be need to be isolated to prevent the spread of infection. Air quality. Allogenic hematopoietic stem cell transplant patients should be in rooms with high efficiency particulate air filtered and more than 12 air exchange per hour. Next, neutropenic diet. Well-cooked food, well-cleaned uncooked raw fruit and vegetable are unacceptable. Avoid junk foods, curd, honey. Good hydration. Eat only meat that is fully cooked. Avoid drinking unpasteurized milk. Next, about the skincare. Daily shower. Daily inspection of skin site likely to be portal of infection. Perineal care. If menstruation not used happens. Rectal thermometer, enemas, suppositories, and rectal examination are contraindicated. Oral care. Ongoing mucositis. Oral rinse 4 to 6 times a day with sterile water, normal saline, or sodium bicarbonate solution. Brush more than 2 times a day with soft regular toothbrush. If not tolerated, can use ultra soft toothbrush. Fixed orthodontic appliance and spaces maintenance should not be warm. Next, additional precautions. Plants dyed fresh flower not allowed risk as Aspergillus and Fusarium infection. Household pets not allowed. Healthcare worker and visitors should be vaccinated. Influenza, measles, mumps, rubella, varicella. Patient and family education. Hygiene practice and hand washing techniques. Wash hand frequently, especially before eating and after using washrooms. Instruct temperature technique. Explain about the function of WBC. Meaning of Nadir. Avoid constipation by regular taking a stool softener. Care of assistive device like urinary catheter, central venous catheter line. Avoid exposure with infected person. Stay away from crowd area. Limit visitors at home with neutropenic patient. Wear a mask in public place. Nursing care. Consist of treatment, delivery symptom management, emotional and social support, survivorship and palliative care, including end-of-life care. To take strict aseptic technique with febrile neutropenia patient, use PPE, gloves, mask, cap, while patient care. The goal is to prevent infectious complication or detect infection at the earliest possible stage. Administration appropriate empirically antibiotic is to take place within 30 minutes if hemodynamically unstable and 60 minutes if hemodynamically stable patient. Standard precautions, appropriate patient placement, clean and disinfect patient, care equipment, textiles and laundry management, safe injection practice, proper disposal of needles and other sharp objects. Pick line care. Avoid strenuous activity for the first 48 hours. After the line balance, avoid heavy lifting and strenuous activity. Wash your hands. Always wash your hands before caring for the pick line. Change the dressing weekly, or more often it gets wet, dry, and or loose. You can ask someone for help change the dressing because it requires 2 hands. Flush the line. Flush the line immediately after finishing an infusion of drugs or fluids. Scrub the hub. Emotional and social support. Good communication is key. Oncology nurses routinely transmit and explain information that is complex and might be emotionally charged. Diagnosis, treatment, and prognosis through verbal and non-verbal communication. Nurse convey compassion and easy. The patient pathway from diagnosis through treatment to recovery, survivorship, and of life care. This compassion was highlighted during the COVID-19 pandemic. Thank you.
Thank you, Mr. Dilip. Thank you so much. I think for a very short and very to the point presentation. Thank you very much. So, Dr. Sierra, can I request you to take up the questions? So we have few questions. The first
Yes,
one
yes.
is role of filgrastim in febrile neutropenia.
So, this is already we discussed. It routinely is not stable febrile neutropenia. We routinely not use, or during the induction which we also not use. Only once his child is in remission and he had significant hemodynamic issue, then we use. In solid tumor, people are using prophylactic, but in hematologic malignancy, only in the sick patient, when sepsis is controlled, then it will help. Otherwise, in active sepsis, GCSF will not work.
Fine. So we use only when we know that the patient is in remission and they are very sick enough to have a febrile neutropenia just to tide over the crisis.
Yes, yes.
So thank you. So
Long-term
the second
survival benefit
question,
is not shown. Yes.
yes, completely agree. So it's just the GCSF use prepones the neutrophil recovery just by 24 to 48 hours. But as Dr. Siaram said, the survival benefit is not seen. So whenever we have an active disease, doubt about the active disease in mind, we usually don't give GCSF.
So
The next question is regarding the
chlorhexidine.
chlorhexidine mouthwash can be used in FN patient.
Yes, definitely. Chlorhexidine purpose is to clean the mouth and decrease the bacterial load minimum. So chlorhexidine definitely used very regularly to maintain the mouth hygiene. And if there is a oral mucositis, then other like cold water, yeah, bitter, baking soda gargling will help to soothe the mucosa. Otherwise, chlorhexidine is very important for decontamination of the oral cavity. So we
I
need to
completely
maintain
agree.
regular.
Only thing, whenever they have mucositis, it might be irritating. So as you said, diluting it and using it might be a better option whenever they have a
Active mucositis.
mucositis also, right? So we sometimes tell them, the salt is the natural antibiotic. So even salt water gargling is sometimes we suggest them to do.
Yes.
If at all they are worried about using chlorhexidine, which may irritate the mucosa.
Yes.
So the third question is regarding if the patient is reactive to ciprofloxacin in monotherapy, what should be given?
We can third generation oral cephalosporin like cefoperazine, etc. can be used easily.
Fine, okay. And why GCSF is not given in the induction phase is a question by the same person.
Yes, definitely, because in the active marrow, without clearing the blast will come and out. No healthy neutrophil or monocyte will be there. So they will not help to fight the infection anyway. So first by induction we clear the marrow from the blast. So because
Yes,
of that,
completely agree.
yes.
Yes, completely agree. So basically, the GCSF works on the neutrophil precursors, the myeloblasts, to get them matured. So as we discussed, it just accelerates the process of maturation, and it precedes the recovery of neutropenia by 1 or 2 days. That's all. But whenever the marrow is filled with blast and there are actually no good myeloblast precursors to produce the mature neutrophils, any amount of GCSF is not going to help. So that is one reason. And second reason is there is a theoretical concept that giving GCSF in a leukemia patient or in patients with myelodysplastic syndrome can predispose to increase in the blast population. So there is another theoretical concept also. So basically, it's not much useful and it may harm also. But as we discussed, if the child is on the deathbed because of infection, we may still try as a last resort, but that is the least useful measure that is found in the febrile neutropenia.
The theoretical risk of malignancy is still there.
Exactly. So, are there any other questions? It's very happy to see there are 50 participants till the end. It's very good number. And thank you so much, Dr. Siaram, for moderating the session so beautifully, and Dr. Henuka, Mr. Dilip Singh for the wonderful presentations. Finally, the take-home points should be that febrile neutropenia, it's an emergency. Though we are seeing it every day, we can't become complacent and take them lightly. Any child who is on induction phase, even without fever, if they come with some complaints, should be treated immediately with antibiotics and utmost care, because children can collapse and they become hypotensive crash within hours. If a normal child takes 10 to 12 hours to develop septic shock, all these children on neutropenia will only crash within 1 to 2 hours. So that's why we need to start antibiotics at the earliest after the cultures. And whenever they have a PICC line or port line and there is a hemodynamic concern, if you're not able to reach the medical team immediately, better to use a new peripheral line access to give the antibiotics and cap the PICC or port line if we suspect that they have a septic shock because of the PICC line or port. And definitely the rectal suppositories, rectal paracetamol should be avoided.
Totally
Even
avoided.
if someone tells by mistakes, the sister should be aware that it should not be given in a expected neutropenic child. Often they come with a CBC done 2 days before. They would have done a CBC on OPD basis that may look normal, but 2 days later, even 1 day later, when they come with a significant fever, the counts could have dropped in 24 hours also. So we will never handle them for any